Hello. Good afternoon, everybody. We are going to start with this afternoon session, we have a great program. We are going to hear about opinion of the possible neurodevelopmental and progressive course of developmental epileptic encephalopathy. And I'm expecting a very exciting and interesting session. We start now slightly delayed, and it's my pleasure to introduce the first speaker, which is Professor Ingrid Scheffer, which she really doesn't need any introduction, but everybody knows his long-dated experience in the field of DE and genetics. And please, Ingrid. Yes.
Thanks very much, Eleanor, and I just wanted to emphasise how wonderful it is to be at a meeting where we're talking about developmental and epileptic encephalopathies all the time. It's very exciting. I've been given the exciting remit of talking about are these progressive diseases, because there's still a bit of debate out there. Is it progressive? Is it not progressive? And I think the answer is pretty straightforward, and I hope you'll agree by the end of this symposium. I've been asked to focus on clinical evidence, and I'm trying to make this go forward. Let's see if that works. Here's my disclosures. Now, I know there have been a lot of talks here on the topic with a lot of definitions, but I'm just conscious that not everyone will have been at all of these talks. And I just wanted to reinforce the concept of developmental and epileptic encephalopathy, or DEE. And it really brings together three factors: etiology, epileptiform activity, and developmental impairment. Of course, now we know that at least 50% of the patients we can find the etiology, most commonly genetic, but it can be structural and it can be acquired. This seems obvious, but patients need to have epileptic activity at some stage in their development of their disease. They may not have it at the beginning, but it must occur, or they do not have an epileptic encephalopathy. And of course, this process has to have an impact on development. That may be slowing, or that may be regression. So first, let's drill down on the topic of an epileptic encephalopathy. And of course, our prototype is infantile epileptic spasm syndrome. And here you see a 6-month-old monozygotic Indian twin girl who I look after, and she developed these epileptic spasms with the classical EEG of hypsarrhythmia. And the concept here is that you have this etiology that produces epileptiform activity, and this abundant epileptiform activity then causes developmental impairment. And these babies often stop interacting, stop fixing and following, lose head control, stop smiling. In 2017, we expanded the concept to that of a developmental and epileptic encephalopathy, because we realised that once you knew the etiology caused developmental impairment, and as well as that, you have a superimposed epileptic encephalopathy. And of course, our prototype here is Dravet syndrome, due to pathogenic variants in SCN1A, which encodes the pore-forming alpha subunit of the sodium channel. It's really important that we remember that these diseases are far more than seizures. They have a whole range of comorbidities. These are the common ones, but we can also have particular genes with less common problems, such as cardiac, musculoskeletal, hearing, and vision. And within the DEEs, we have a range of well-described electroclinical epilepsy syndromes. And here you see the well-known ones, you see the best described and well-established ones is what I meant. And some are generalised as seen in pink, some are blue, focal. They can be generalised or focal or unknown onset in yellow. And then here you see the purple are combined, generalised and focal. And next to them you see their predominant etiological subgroup. So when we think about these diseases, we used to talk about 60 genes, and now in 2024 we know there are more than 900 genes just for DEEs, though these genes overlap with milder epilepsies. And when we think about the processes involved in these from a mechanism point of view, first thing everyone thinks about are channels and transporters, and these include, of course, sodium, potassium, calcium channels, but also many subunits of receptors such as GABA and glutamate receptors. We now know that cell signalling and metabolism is really important in the DEEs, with a number of proteins within the mechanistic target of rapamycin pathway that are implicated, and also those involved in G protein receptor signalling. And more recently, we've found that epigenetic regulation is implicated, with a number of proteins involved in these pathways being identified as causing DEEs. And of course, one can't forget the synapse, with many of the synaptic proteins involved, including the snare complex. So I just have one slide on infantile epileptic spasm syndrome, which of course refers to the triad that I've already referred to of epileptic spasms, hypsarrhythmia, and developmental slowing or regression. But there are many studies over the last 20 years showing that the earlier you treat, the better outcome. And the longer duration of hypsarrhythmia, the more severe disease. So I think that's sort of well-established news. We all want to diagnose it rapidly so that the child has the best outcome. I thought I'd focus much of my talk on Dravet syndrome because there's been so much work on this clear genetic DEE. And I'm just showing this puzzle, which is something that we created some years ago now, but really to get across the concept that this is a complex diagnosis with many facets to making that diagnosis. But if we want to think about whether it's a progressive disease, I think the first place we should look is at the developmental course of Dravet syndrome. And here in an analysis of 205 Dravet patients, we looked at when the developmental slowing occurred. Now, we're all taught that it occurs between 1 and 2 years of age, and you can see here that that is indeed the peak time, with half the patients slowing at that time. Interestingly, though, a quarter slowed before 1 year of age, and some were never normal, which is not what we're taught. But at the other end, it's also fascinating. You can be normal to 5 years of age and then start slowing. So the slowing may be subtle, it may take a while to become really evident. And we found the median age of developmental slowing or plateauing in this group of 205 SCN1A positive Dravet patients as 20 months. So that goes with the teaching, but the spectrum of when that child slows. So they go from essentially normal development, there may be some subtle abnormalities, to intellectual disability. And how severe is that intellectual disability? Well, in many studies, 50% of individuals have severe intellectual disability, 30% moderate, and at best 20% mild, with very rare normal individuals. So this is a syndrome where you start off with normal development usually, and then you end up with severe intellectual disability. So this is clearly a progressive disorder, and you're going to hear a lot more about the fine detail of this progression in cognition from Professor Lagar, who's done a lot of work in this area. Then let's talk about motor manifestations. And if we think about motor progression in Dravet syndrome, is it normal? Well, perhaps not quite, because the average age of walking is around 16 to 18 months. And I'm sure many of you have seen these toddlers, and they have physiological ataxia, and that continues for longer than you would usually see, and is certainly part of the syndrome. They then settle into their childhood gait pattern, but as they're older, they develop mild pyramidal signs, and you only find these if you examine them carefully. They then develop this unusual crouch gait, which is manifested by flexion at the hip, flexion at the knees, ankle dorsiflexion, and plano abducto valgus bilaterally. And this unusual crouch gait, when we first published on this, we said it became evident from the age of 9 years, but now I've seen 3 and 4-year-olds with it, though I do think it tends to become more evident with pubertal growth. So here you see examples of this crouch with essentially normal gait in a young child, then emerging crouch, and then you can see the young lady on the right with quite a severe crouch, and she's about 18. Now, in some individuals, it actually gets worse, and you'll see here a young man of 20 on the left with quite a severe crouch, but watch, he can run rather beautifully and doesn't fall. And the man on your right is 27 years old. He's my only patient with Dravet syndrome who's actually gone to surgery, orthopaedic surgery for his gait at 22. It made a difference for a few years and then he's declined. And you can see he's got a profound crouch with dystonia. We've tried Cinemet for it without any effect, and I'm worried that he won't stay walking, but time will tell. So what about this evolution of gait in Dravet syndrome? If you look at the figures here, you can see that 0 to 5 years, normal or mild crouch. By 6 to 12 years, you have 50% with a moderate crouch. And by more than 13 years, 57% had a marked crouch. And how does this impact on their life? Well, using the functional mobility scale, which was devised for children with cerebral palsy, you can see that by adolescent and adult life, they are needing more assistance, as shown in the green bar, and some are wheelchair bound. And I'm sure many of you are used to seeing your older adolescents or adult patients come in a wheelchair. Turning now to musculoskeletal complications, here you see one of my 20-year-old patients with Dravet syndrome who developed a scoliosis quite rapidly over a few years following puberty. And you can see here that he's had surgery, which was delayed due to COVID a year or two, but with a very nice outcome. And I have to say, with time, I'm seeing more patients with scoliosis. It's not common, but I don't think it's that rare in Dravet syndrome. I think gastrointestinal features are important, and dysphagia was identified by Caterino and Sisodia and colleagues as beginning after the 4th decade. But we do see many patients with earlier dysphagia with chewing and swallowing difficulties, drooling, choking and vomiting, anorexia and constipation. And I just wanted to focus for a moment on gastrostomy because I've been fortunate to visit many centres around the world, and the percentage of patients with gastrostomy varies dramatically from just 1 or 2% to above 20%, depending on the country, I think. So it's an interesting observation in different practices. There are many problems that evolve in older age. Behavioural problems often occur in adolescence and can continue into adult life, often coupled with autistic features. I have an adult of about 40 that they cannot get to come in from outside every night. He just wants to play with bits of trees, branches, and it's a huge problem, far greater problem than his seizures. And this has got worse with age. Non-ictal urinary incontinence, impaired activities of daily living, and just to highlight that their mortality risk doesn't go away. You are still at risk of SUDEP as an adult with Dravet syndrome. I wanted to change tack in the last few minutes to a different genetic DEE called PCDH19 clustering epilepsy. This has a very characteristic phenotype with infantile onset of clusters of tonic-clonic and focal seizures triggered by fever and vaccination, and it follows this fascinating inheritance pattern of X-linked inheritance with male sparing, which means the males are unaffected, as I'm showing you here, and the females are affected, unless the male happens to be mosaic. And you can see here this disease is not always a DEE. In fact, mostly it is not, but in some individuals, such as over here and in blue, you can have a Lennox-Gastaut phenotype. As well as the mild people were shown in orange, the blue affected women are severe. And you can see here by these little quarters that you have autistic features commonly, severe behavioural problems, depression, and the important, the important finding in these pedigrees that we studied with the Andrade group from Canada is that we found that quite a number of the women now highlighted in red presented with psychotic disorder. So again, another evidence, more evidence of progressive disease. And we found that if the girls or women were over 11 years of age, 21% had psychotic disorder, which fell into a number of different psychosis groups, most commonly schizophrenia. Median onset of psychosis was at 21 years, but could be as early as 11 and as late as 28 years. The psychosis occurred in the context of ongoing seizures in 7, but 2 were only having seizures when they had recurrence of their psychosis. And interestingly, it's across a spectrum of intellect, from normal intellect to severe. So this is our DEE group down here. And many had pre-existing behavioural problems of autism spectrum disorder. And this wasn't all the psychosis in our group. We also had 2 other cases, one with postictal psychosis, which was recurrent, and one with major depression with psychosis, suggesting it may actually be a bit higher than 21%. It's very important to diagnose this for families. So this is just some evidence. This could be a whole day's discussion on how the DEEs are progressive diseases. I think intriguing questions are why don't all patients with this specific genetic disease have this manifestation, be that psychosis in PCDH19, be that severe intellectual disability in Dravet syndrome. Is it due to the type of the pathogenic variant? We know that's not the case in those diseases, but today we heard some evidence that it could be in some, or is it their genetic background? As we head towards precision medicine, we need to think about curing all aspects of the disease, not just the seizures. I'd like to close by thanking my team that I work with, which is a really inspiring group of people, my major collaborators around the world, and most importantly, patients and families. Thank you.
Thank you so much, Ingrid. This is an excellent presentation. I suggest we comment and question after all the talks, which are pretty much related to each other, so it's okay with you. Yeah. And it's my pleasure now to introduce Marina Trevisano from the Ospedale Bambin Gesù here in Rome. She will talk about the electroclinical features in DE over time. And please, Marina.
Thank you for the introduction, and good afternoon to everyone. These are my conflict of interest, and in the following 20 minutes, we will try to answer to the question whether EG features might indicate a progression in disease. And to do this, we will start to see the DEE as a whole group, and then we will focus on some example of specific DEE starting from Dravet syndrome. And at the end, we will try to find out some conclusion and the answer to this question. So I want to start from a typical AG evolution in a condition which is clearly neurodegenerative, which is NCL type 2 disease, where epilepsy is one of the main clinical features. And in a typical neurodegenerative disorder, we can have that at the beginning, for example, in the presymptomatic stage, at the age of 18 months, the EEG can be absolutely normal with a normal background activity and no epileptic abnormalities. With the onset of epilepsy, something happens and change even in the EEG. And as you can see, there is progressively a slowing of the background activity, of the cerebral activity, the disappearance of the background activity, and the appearance of epileptic abnormalities that might be focal and as well as diffuse. And during the advanced stage of the disease, we can even see a reduction of the amplitude of the cerebral activity, the complete disruption of the background activity, and in some patients, there might even be a reduction of epileptic abnormalities. This can be the evolution in a typical neurodegenerative disorder. But what happened in DEE? We tried to understand this in this large study on 160 patients, taking the EEs as a whole group independent from the etiology that was variable. Of course, a patient with Dravet syndrome represented a good part, a great part of this cohort, and also this patient had a huge variability in terms of severity. And we analyzed the EEG features in terms of background activity and epileptic abnormalities, both at the onset and follow-up, and also we analyzed the cognitive function at the end and at the onset and follow-up. And what emerged is that in a patient with developmental and epileptic encephalopathies, the majority of them, since the onset, there is a developmental delay, even if there are some that can have a normal assessment, neurological assessment, and cognition. But with the time, the patient with the normal evolution became very few, and most of patients have at the last follow-up developmental delay and intellectual disability, which is in most of cases moderate to severe. What about the EEG? The background activity is in most of patients poorly organized, slowing, independent from the etiology, even if there are some patients with normal EEG at the onset and normal EEG at the follow-up. And there are even patients with normal EEG that can deteriorate and become slowing with losing of the background activity, and as well as there are patients which starts with the suppression bus pattern that, if adequately treated, may be modified over time and disappear. Leading to, however, a pathological EEG activity which is slowed and not well organized. In terms of epileptic abnormalities, we can say that they can vary during the evolution. We can have a patient with focal, multifocal, or diffuse abnormalities, and they can vary from one to the other towards the outcome. There is also a part of a patient who do not have epileptic abnormalities, both at the onset and follow-up. And this is something also to consider. So what emerged is that there is surely an evolution in the EEG features in patients with DEEs, and that there might be a progression in some of them. Looking at the example of Dravet syndrome, I want to show you this study that we performed several years ago, where we analyzed the EEG every 6 months in a cohort of 22 patients and for a period of 5 years since the onset. And as you can see, most of the patients, the EEG at the onset was normal, and around the age of 1 year, there was the peak of epileptic abnormalities, and slow waves started to appear, and also the slowing of the background activity. And these results were later on confirmed in a larger study recently published, and also here you can see that from normal EEG there is progressively a slowing between the first and the second year of life, which is also the period in which in a patient with Dravet syndrome there is the appearance of cognitive problems, some language delay, and some some stagnation. This is the typical evolution of a patient with Dravet syndrome. You can see at the onset, 6 months, he has a quite good background activity, a normal posterior rhythm over bilateral occipital regions, and in some of them there could be a photoparoxysmal response. But with the evolution and the ages and the years, this patient at the age of 8 years, you can see here there are mainly theta rhythm, and is not more detectable a posterior background activity. There are even some focal epileptic abnormalities, and then during the adult age, in some of them we can find also a reduction in amplitude of the cerebral activity. Moving to another condition, I bring the example of SCN8A in this study by Elena Gardella on the electroclinical phenotype of this patient. It is reported that most of patients, 91% of patients at epilepsy onset, had the normal or mildly abnormal interictal EEG. And this persisted for several months after epilepsy onset, and then deteriorated with the time, with the appearance of a slowing background activity and multifocal abnormalities that were prevalent over bilateral posterior regions. And again, this is an example of a patient with SCN8A-related DEE. Here it is at the age of 4 months, at the onset. We can recognize a quite good posterior rhythm and a more fast activity over bilateral frontal region, not epileptic abnormalities, but with the time there is the prevalence of theta-delta rhythm and that are diffuse on all derivation, and there is not more the differentiation, the gradient, the anterior-posterior gradient on the EEG. And this is a patient at the age of 13 months. Again, here we can have, not in all patients, but this may happen, there is a reduction of the amplitude of the cerebral activity. And this might be the expression, the EEG expression of a progressive cerebral atrophy that has been reported, and in this patient, this is an example of a patient with the cortical subcortical atrophy during the first year of life, when there are many seizures and often difficult to treat. And this is something that has been seen even in the mouse model, when half of mice develop abnormal EEG findings and seizures, leading to premature death before 6 months of age. So this is to support the hypothesis of a progressive nature of this condition. Another example is that of CDKL5 deficiency disorder. Only you know that in this DEE, it has been distinguished the presence of 3 stages, which are that of early epilepsy during the first 3 weeks of 8 weeks of life, with epilepsy onset and a quite normal EEG, interictal EEG. Then there is the phase of the epileptic encephalopathy with the appearance of epileptic spasms and regression. And then after the age of 2 years, there is the refractory epilepsy with the prevalence of tonic seizure and myoclonium. And this distinction in 3 stages has been recently confirmed in a study by Francesca Darra with the Argentinian group of Caraballo, and they analyzed the interictal EEG, again confirming this evolution. And this is again an example, a patient at the age of 8 weeks, seizure onset with a quite normal EEG, interictal EEG, no epileptic abnormalities, and then the phase of the epileptic encephalopathy with the hypsaryctic trace pattern with the multifocal abnormalities prevalent over posterior regions, absolutely the lack of a background activity and EEG organization. And after treatment, adequate treatment, however, slow waves, slow rhythm persist, and also multifocal abnormalities, even if the activity is more continuous and the hypsaryctic pattern goes into remission. This is a study on quantitative analysis in patients with the CDD, and this is an interesting study in which they found that there is a higher amplitude in patients with the CDD compared with the controls, with the control group, and this, the power was higher for all rhythm, but what is more important is the ratio, the alpha delta beta delta and alpha theta beta theta rhythm. That means that in this patient there is the prevalence of delta and theta rhythm compared with the controls. And even more interesting, they found that there is a correlation between this EEG biomarker and the clinical severity scale of this patient. Last example I want to show you is that of KCNQ2-DEE, and this is a little bit different as evolution, because in patients with the loss of function, we have that they start with the seizure during the neonatal period, usually during the first week of life, and soon they have multiple seizures per day and a suppression burst pattern, which in most of the cases with an aggressive treatment with sodium channel blockers, if we are lucky, we can resolve. And what remains in this patient is a slowing background activity, some multifocal abnormalities, and in this paper by Sarah Verkuisen on adult patient, they report even some adult patient with remarkable findings on DG. So, coming back to our question, do EEG features might indicate a progression in DEEs? We can have a different scenario, and the first is that we can start from normal background activity, which became slowing, so we can have the lacking, the disruption of a good cerebral activity, and this may be more or less impaired, for example, less in Dravet syndrome, CDH19 clustering epilepsy, more more impaired in SCN8A, CDKL5 deficiency disorder, and for example, even epilepsy of infancy with migrating focal seizure. On the other hand, we can have another scenario, which is that of those conditions which starts often during the neonatal period, like KCNQ2, SCN2A, S6BP1, DEE, which usually starts with the suppression burst pattern. And here, if we treat adequately this condition, we can solve this EG pattern, and what remains is, however, a slowing background and even a severely impaired EG. What is the major determinant seems to be the etiology, and also age at onset of seizure is important as regards the clinical outcome, also in the EG feature, and as well as seizure frequency, seizure types, and the recurrence of status epilepticus. Perhaps treatment may be one of the major determinant in this pattern regarding the outcome in terms of electroclinical phenotype. And in conclusion, a clinical progression may appear in genetic DEEs, manifesting as a slowing or a disruption of EG background activity. In most of cases, we have that DEEs start with the normal background activity, which deteriorate with seizure onset. So it's important the occurrence of seizure, the start of seizure, and the severity of the clinical phenotype might correspond to severity of the impairment of the EG in those patients. And of course, the progression may be more or less rapid and variable between different etiologies, but even in the same etiologies. Treatment may be one of the determinant factor that can influence even this variability. And I thank you for your attention.
Thank you. Thank you very much, Marina. Let's move with our third speaker. So it's my great pleasure to introduce Professor Lieven Lagat. Lieven is Professor of Pediatric Neurology and Head of the Pediatric Neurology Department at the University Hospital in Leuven, Belgium. And he will cover the topic on cognitive functions in the EE, what long-term observations tell us. Thank you very much, Lieven.
Thank you, Nicola. Thank you for inviting me to give this talk. So this is the title. These are my disclosures. And we will touch upon cognitive problems in the DEEs. And I think the main issue actually for many of the families that we see, this is the key issue, the cognitive problems and also the behavioral problems, I have to say. And for many families, this is actually a greater burden than the seizures itself. And also I see what is happening right now with the new modifying therapies that are coming. Actually, the outcome of these studies will include, as a primary outcome parameter, I would hope, effect on cognition and behavior. So they are really important in the long run. What is our discussion today is, of course, what are all the factors that are contributing to these long-term cognitive problems in children and adolescents with epilepsy and with DEEs. And we also have to think, is there a stagnation of some of these factors or functions? Is there a real regression, or is there a slow progress? I think everything is possible, but the large majority of all our children, they do have a slow progress. So the distance between, or the difference between normal development and actually the development that you see in these children is really becoming bigger and bigger with age. So actually, in a way, you will see more and more problems appearing when they get older. And what I feel when I look through the literature, that actually if you look at the different etiologies, actually there might be a common pathway into adulthood, because if I read all these cognitive problems and also motor problems, motor is another key issue, as Ingrid was telling about, many of these patients, they do develop a sort of a common problem. So I think that's also something that we have to deal with in the future, to see how specific all these cognitive, behavioral, and motor problems are in the DE at the long run. So just to show you what you already know, actually it's a frustrating slide. If you look at the large cohort of patients with epilepsy, you see that they really have a lot of associated problems, comorbidities, multimorbidities, but you see that intellectual disability is high ranked, so the large majority of the patients with epilepsy will develop intellectual disability, especially in the DEE group, I have to say. So if you look in general, and so this is probably the study with the longest follow-up, 50 years, and this includes all sorts of patients, so there's not etiologically based, or it's not only DEEs or normal epilepsies, but the whole group. So this is the very well-known study of Silampa. Actually, if you look 50 years down the road, 32%, so one of these three of these patients will develop or is known with moderate, severe, or profound ID, intellectual disability. And as you can see, there is a close correlation between having ID and the chance to stay seizure-free in the long run. So 1/3 of all the patients with epilepsy will develop intellectual disability, and in the DEEs it will be much, much more, almost 100%, almost by definition, of course. There's a very nice prospective study, I would say, in the Scandinavian countries, looking in a cohort of children with epilepsy, what is happening again, and you see that the blue line is intellectual disability, so the developmental delay is decreasing because it makes place for for intellectual disability. So you also see here already at the age of 17 years, and again, this is a cohort of all epilepsies, not only DEEs. We are approaching 30%, so here it is already 20% at the age of 17 years. What is also quite important to stress, a lot of behavioral problems, but with adolescents, you see the two main problems that are seen in adults, namely depression and anxiety disorders. But already in adolescents, you see this happening. This is, again, not only DEE. And more specifically looking at org populations, the DEEs, there are a couple of studies, and of course I will touch upon Dravet syndrome again because this is the prototype of a DEE. But this is a study looking at behavioral checklists, so not intelligence or intellectual disability, and they looked for different parameters to different epilepsy syndromes, and they compared it with 70 percentile of a child with autism spectrum disorder. So this is already a lower range for autism, and you see that many, if not all, of course, of our DEEs, they really fall below for many of these parameters. Now, we try to understand why that is, why in DEEs we see all these cognitive, behavioral, and motor problems. And this is very difficult to understand because this is not a yes or a no. These are different factors playing together. And you all know these factors. And I think, and it has been stressed also for the EEG findings in the previous talk, etiology is important, probably a bit more important than everything else. Age at onset is really crucial, I think. So if your epilepsy starts earlier, like in the DEEs, more likely you will have severe and more severe intellectual disability. But also seizure characteristics, EEG abnormalities, treatment. You all know the study of the adults with Dravet syndrome. If you take away the sodium channel blockers, they start to talk. This was only one case in that very well-known paper in 2012, but it shows that ASM can have a long-lasting effect on intellectual disability, and also, of course, also the social environment the child is raised in. So all are equal, but some are more equal than others. That's what I would say. And I will give you some examples. Let's go to this very well-known picture, the SCN2A epilepsies. And we all know that, like in many other genetic epilepsies, you have benign phenotypes, you have more severe phenotypes, but we also see, like in 8A as well, you see a group of children with intellectual disability, but without epilepsy. So in a way, and this is very nicely shown in this paper, in a way it shows you already that the gene abnormality on itself might be enough to explain the intellectual disability, nothing to do with the seizures or with the epilepsy or with the frequency. So on the right side, you see here, this is usually a loss of function in SCN2A. They don't have epilepsy, but they still are seen with intellectual disability and or autism. So this is one just indirect proof that gene abnormalities on itself without epilepsy can cause these intellectual disabilities. And if you go on with that disease, with that particular disease, SCN2A, and you look at the studies, the long-term studies, so this is a follow-up study for 25 years, almost 25 years in a large cohort of these children. And this is the picture that you will see for many of the DEEs. There is a so-called, if you look at the composite figures or at the scaled figures, the standardized results, it goes down. And you see it for many of the fields that we are looking at, motor, communication, socialization, and daily living. You see that there is a decrease. But that's not to say that each individual cannot gain in a way. They gain not as fast as a normal person, so the distance becomes larger, and that's why this slope is going down. And if you look, and I'm sorry for the busy slide, if you look at individual trajectories, and you look at, so they're always pairwise, so this is by age, and this is year from initial evaluation. If you look at different, again, functions, you see for many patients, there is a stagnation or an even increase, but not good enough, of course. But a pattern that can be seen, and this is now specifically for SCN2A, if you, for instance, look at receptive and expressive language, there seems to be a group that actually is not winning at all anymore, and the other group is a little bit increasing. Again, it will not reflect in the scaled results, but here also you see the same thing, that some of these children are really not gaining anything anymore throughout life, and some of them are gaining more. So you really have to look at these raw figures, these raw data, to understand these trajectories. And it's true for many of the DEs that you will look at. Another example, just to illustrate again how important motor function is, this is a recent paper about STXBP1, one of the more frequent rare DEEs, and again, they focused not intellectual disability, but here on communication and speech, and so you see that the large majorities of these adults with STXBP1, they really have 72% or nonverbal. So that's actually, again, a very severe DE in the long run. And you see also for the motor problems, many of these patients, not all, but many of them have also motor problems. And I repeat my feeling that we will see this in many DEs, and we really have to find if this is a specific motor pattern or is it something that is common to all the DEEs. Another example, a recent paper on SYNGAP1, a small study, very well done, of course, by the group of Daniel Andrade in Canada. They looked at adult phenotypes again in SYNGAP1, and they focused again on, for instance, language. And you see that 50% of the adults are having problems, and it was only 39. So there was like a contradiction, because adults did a bit better for all these functions, but there is a very important note in adulthood. This actually is reflecting more problems in daily life than in childhood. So again, for all these examples, we do see a similar pattern. Now, let's focus on two diseases that I try to understand better and better, the TSCs and the Dravet. And why do I present again on EpiStop? Because this trial, as you all know, tried to find out whether there was a difference if you give preventive vigabatrin in a child who developed epileptiform discharges versus a normal follow-up of these children. And you all know the results. At the age of 2 years, there was a clear difference, at least in the EpiStop trial. These children that were treated preventively developed less frequently focal seizures, and I think very importantly, none of them developed epileptic spasms or infantile spasms. And it was that last thing was also confirmed by the PREVENT study. But the thing I want to focus on, this EpiStop trial was also looking at development, and you also know the results at the age of 2, which is too young, of course, but at the age of 2, there was no difference in preventive treatment versus non-preventive treatment. This is the main result of the study. But actually, we looked much more in depth, and we did all the EEG work for that study. And there are 2 papers that are illustrating the importance of EEG in developing intellectual disability and behavioral problems. So you have to understand, and this is looking, now this first slide is looking at the very first EEG of all these children with known TSC, but the very first EEG was done between the age of 1 week and 4 months, so very early. These children did not have epilepsy yet, and we looked at the EEG in a qualitative way and a quantitative way, and we correlated with the outcome. So first of all, if you look at autism or developmental disability, it's not really great. I mean, almost 30 to 40% of these children eventually develop autistic traits or autism. And you see that the scores are actually between 60 and 80 on average. But if your first EEG is abnormal, and especially if there's a background abnormality, and the background abnormality is defined by focal slowing, probably reflecting underlying tumors, but we could not prove this. But if there's focal slowing in the very first EEG during follow-up, and it's not highly predictive, but you see a clear difference, many more children will develop autism. If your first EEG is abnormal, especially this mature, so focal slowing, you see that the scores are even lower, and this is statistically significant for the 3 domains. So it's not the end of the world, but you can already, with the very first EEG, say something about the future. And we went on, because the next study, we looked then at the first EEG with a spike. So that happens a bit later. Some of these children already had seizures, and some of them really did not have seizures yet, because this was the first biomarker, an EEG finding, and then later on the seizures. But we looked again, we correlated this age at which there was a first spike on the EEG with the outcome. And again, it is statistically okay, clinically significant, we have to see, but if your first epileptic abnormality appeared beyond the age of, let's say, 160 days, then the likelihood of developing a normal IQ, that means above 70, which is not really normal, is much higher than if your epileptic abnormalities would develop before that age. And that was also seen for cognition, language, and motor. So EEG findings, and this was independent of treatment and genetic background, EEG findings can help you to predict a little bit, I'm not overdoing this, a little bit the future. And this was also shown in a much better way in this paper, looking at different factors in TSC that would predict intellectual disability at the age of 7 years. And you can see with me there are 3 trajectories, but what is really important, what is predicting actual intellectual disability in TSC? It's not one factor, it's of course an interplay of different factors. You have your gene abnormality, TSC2 is always doing worse than TSC1. You have your tuber load, and then your seizure frequency severity. And that's actually is predicting your estimated IQ at the age of 7 years. So again, it's an interplay of different factors. Now let's move to this prototype, Dravet again. You hear a lot about Dravet, but I repeat, this is the prototype. This is a very homogeneous group to study. And you will see a lot of papers with this sort of picture. This is a cross-sectional study in an old Belgian population with Dravet syndrome. Very frustrating again, because you can see with me, beyond the age of 10, none of our children actually reached a level of 40 on a scale of 100. So it's really, that's what we all know in Dravet, of course, for motor development, cognition, language and communication, and social development. And already Rima Nabud in 2030 warned us, and actually this is confirmed more and more. So first of all, she did find similar findings. Again, this 10-year, I mean, also beyond the age of 10 years, nobody was normal anymore. But she said in that paper, please don't think that this is a consequence of only the epilepsy. The gene abnormality is also important. So we tried to find this out, and we looked at different papers to look at the evolution of cognition in Dravet syndrome. And there's a nice cohort being followed in the Netherlands. And I found this recent paper looking at the follow-up. So they have data in 2015, and then they have data 7 years later in 2022. And you see the distribution in 2015 was like this. So there were still, and these were all children with SCN1A. This did include GAFS+, not only Dravet syndrome, but there were normal children, the blue ones. Then already almost half of the children at that time were really clinically affected. So that means there was intellectual disability. And then there was like a borderline group. Now, if you do the follow-up of, for instance, the normal ones, there were 15 normal ones, and then 7 years later, there were 9 normal ones. So the other ones moved into the clinically significant group. So you can easily follow that many of these children really continue to develop intellectual disability, but you also have to see the opposite. And probably these are more the GAFS+ children, of course. There were children who were normal or abnormal, and actually only one who turned out to be normal 7 years later. So it's possible in the two directions. And that was also what Joe Sullivan told us, showing us the first results of this natural history study, the butterfly study. Really important studies. There are 2 natural history studies now on Dravet, Butterfly and Envision, and you will see the other one coming up later. And they only looked, of course, only for 12 months so far, and they see that many of these children do really gain, but again, it's always the same. They gain not at the same pace as a normal child, so the difference between normal and abnormal development becomes more and more clear. So you see a distribution of these cognitive functions. This was only based on very, very robust, I would say, like also only the CGI. So you need actually much more neuropsychology to prove this point. But it's already an indication where we are going. Now, when we looked again in our survey, and this included many, many patients with families with Dravet children, and we looked actually through different age groups. So this is infants, preschool, this is primary school, adolescents, and adults. And for instance, learning difficulties, as you can expect, it actually increases, and already by the age of 6, 7 years, you see that the large majority is intellectually impaired. Now, it stabilizes a bit in adulthood for many other things like autism. 1 out of 3 adults, 50% of the adolescents is having a diagnosis of autism in that cohort. This was a survey done by families, so it's not medically proven, all these things, but you see the picture. Now, we tried to see if there was a correlation with seizure frequency. So these are Dravet children. They have all these comorbidities, and we try to find out, is there a correlation between seizure frequency and intellectual impairment, or, as you can see, for other domains like motor impairment, autism, ADHD, and other behavioral problems. We had 2 groups, the 2 extremes, those with a very low seizure frequency in orange, and those with a very high seizure frequency, the highest 10% in blue. And actually, for the large majority, like autism, ADHD, and other behavioral problems, we did not see any difference. So that means that for these domains, probably the seizure frequency doesn't matter too much. It's more the gene, of course. But for speech, which is the more sensitive measure, if you look at cognition, I think there was a difference. I mean, I will not, again, overemphasize it, but there was a difference. So if you have more seizures, you're tending to have less speech possibilities. Also for motor, this was a bit more clear. Seizure frequency was associated with later on motor problems. And I will not go over that slide. There was at that time in 2020 a review, and the only thing I wanted to show that slide, so they looked at different factors again, the ones that we are talking about, that could explain these problems. Now, better data are now available very recently from the group of Andreas Brunklaus. And no surprises, they look at baseline in 2010, and then 10 years later, they look at the evolution of these children, and you see that actually 10 years later, there's not a normal child anymore. Most of them are profoundly affected or severely affected. Now, what is important in that study, as predictors for intellectual disability, they said that there was 3 factors: poor baseline language, severe epilepsy severity, and then the type of your mutation, because they have a scoring system for all these mutations. So actually, in a Dravet child, you can, with these data, you can a bit predict the severity of the intellectual disability. But then came this, and this is my last slides, came this paper, with a bit of a provocative title: Severe communication delays are independent of seizure burden and persist despite good contemporary treatments in SCN1-Dravet syndrome. So this is the first data from this other natural history study, the Envision Natural History Study. First of all, they show exactly the same trajectories of the children in Dravet syndrome. What they also showed, that there was, for language, that there was a stagnation around the age of 2 years. So that's a bit of a new data set. But more importantly, these communication problems were not dependent on the seizure frequency. So if I can go over that slide, so you have to look over here. So they correlate different factors with different factors. For instance, 85 means a very high correlation between status epilepticus and the use of rescue medication, which is quite normal. But for instance, here, the first 4 are seizure frequency, rescue medication, prolonged seizures, and number of drugs. So these first 4, they are not correlated or very weakly correlated with language and communication, as you see here in blue. So that means this study actually shows us again that it's not an easy story. There are different factors, but in Dravet, I think it's, again, an interplay of the etiology, very, very important, as you can see, but also, I think, still about the severity of the epilepsy very early on. Thank you very much.
Thank you. Thank you for this great presentation, comprehensive. It's now my pleasure to introduce Professor Renzo Guerrini from the University of Firenze, and my Institute in Firenze.
Okay.
We'll talk about the neuroimaging aspects.
Okay, thank you. These are our disclosures. Okay, so thank you for this symposium. Now, looking about neuroimaging in developmental and epileptic encephalopathies is not easy because of the great heterogeneity. And you have an overview here of the genetic and also morphological heterogeneity of these conditions, which may arise from genetic and malformations, prenatal, postnatal, infectious, metabolic, and so on. Now, the point is that if we discuss about the metabolic DEs or the neurodegenerative, of course, we already know that there is a clinical and parallel neuroimaging deterioration. Less clear is what happens in the genetic neurodevelopmental, developmental and epileptic encephalopathies and in the so-called pure genetic epilepsies. Now, looking into with detail into this area is very complicated because, as you know, the genes which cause these conditions span from ion channels, which are often supposed to cause conditions without brain lesion, even if recently we have seen that patients may have malformations. So we know there are structural abnormalities in terms of malformations, but we don't know exactly what happens when we don't see structural malformations and have to follow the patient up. On the other side, it is obvious that if we move to other categories like, for example, cytoskeletal or scaffolding proteins, we expect to have structural abnormalities. but not much is known about evolution, with the exception of few of these conditions. I will give some examples, and some of these examples will be biased because they will be accompanied by studies by our team, which is especially interested in neuroimaging in these conditions, but there is some literature in general. We will look about mutations in ion channels, in multiple function proteins, cytoskeletal and extracellular matrix proteins, and in genes causing abnormal vesicle acidification and protein degradation, which also cause a simplified neuronal arborization. Let's start with a reflection. We are dealing with a very large amount of rare conditions, and from these genes for epilepsy results, which Ingrid knows very well, we know that there are more than 1,000 genes related to monogenic epilepsies, and of these, 90% are related to the developmental and epileptic encephalopathies, which means that we have very, very many conditions. Now, while in some conditions progressive atrophy is self-evident, it's sufficient to carry on an MRI scan at a given age, it is very difficult often to obtain follow-up studies if the first MRI is abnormal or normal, because these patients are fragile and a second sedation is not advised sometimes. Also, it is difficult to obtain large cohorts enough to develop statistically significant quantitative studies when you have the suspicion that you have progressive atrophy, but you need a large number of patients sufficient enough to have a power to demonstrate it in 2 subsequent studies or even in cross-sectional studies. And then we have many situations where evidence is not obtained, but which doesn't mean there is no lack of evidence that there is no progression. It is just that we don't know. Now, Dravet syndrome, well, I'm not saying what Dravet syndrome is, perhaps someone before has said already, mentioned. But Dravet syndrome is classically considered as something where you have different populations of neurons which are differently impaired by the loss of function mutation, and in particular you have GABAergic inhibitory interneurons which don't work and cause hyperexcitability in various parts of the brain. So with this description, we don't need to think of something which is necessarily progressive. But indeed, progression is there. This is a morphometric study which has been conducted on 34 patients with SCNY mutations, of whom 22 had Dravet syndrome and 12 are Jeffs plus. In the Jeffs plus population, we included on purpose because we wanted to see whether what we detected in the Dravet were also present, but to a lesser extent in the Jeffs plus. So this is a study of the cortical mantle and morphometric and volume of the subcortical structures. Now, what emerged is a bilateral atrophic changes in the hippocampus, amygdala, and the limbic cortex. Also, that there was a more severe atrophy in Dravet syndromes with respect to those with Jeffs plus, who still demonstrated some atrophic changes, and that the underlying mutation and seizure severity seem to both contribute to the severity of atrophy. If you can look at this line here, this is the line which represents the severity of the scores in patients with higher mutational scores. So where the mutation indicated worse outcome, we had also a more severe atrophic change. And by correlating the atrophic pattern with brain connectivity profiles, the hippocampal formation appears to be the epicenter of the structural change. Now, there is no clear explanation for this, but as you know, connection of the hippocampus make it vulnerable to seizures that originate in many parts of the brain. Does this have some importance? Yes, in our opinion, because now we have predictive scores or predictive elements in the clinical history of the patients, like the fact that age of seizure onset is a strong indicator of outcome, as has been demonstrated in these two subsequent studies. And also, we have a score, genetic score, which is available in this site from the work of Andreas Brunklaus. So once we have a child starting seizing early with the characteristics, we can now quickly demonstrate a mutation, and we have a mutational score which indicates about outcome. Treatment should be started early, should be treatment for Dravet syndrome, and we should not wait, this is my personal opinion, but I think it's shared by others, should not wait to have full-blown Dravet syndrome to use the proper medications. Because the brain atrophy is also a factor that should be considered. This is another ion channel, is the TMEM63B, which we have studied recently, and have associated with a developmental and epileptic encephalopathy. And we added progressive neurodegeneration. Now, this is an interesting story for different reasons. First is the function. This is a stretch-activated ion channel, which is sensitive to mechanical and also osmotic stress. These patients, most of these patients, had been diagnosed as cerebral palsy or are not being diagnosed at all. Now, what emerged is that they had a first MRI scan that could be either normal or already show signs of periventricular leukomalacia-like lesions, as you can see, for example, here or here. But when repeat scans were performed, what became apparent was that there was a progression in the white matter abnormalities, a progression in atrophy, and atrophy not only impaired the brain parenchyma, but also the cerebellum and the brainstem. Also, another important finding in these patients is that a number of them had episodes of hemolytic anemia, because this channel is also expressed in red blood cells. And these gain-of-function mutations caused a crisis of hemolytic anemia or chronic anemia in these patients. And you see here that some had a very thick skull whose thickness progressed with age, which is an indicator of strong anemia in the bone. So this is progressive, and progression is related to epilepsy. Progression is related to the response of cells to the stress, the osmotic stress, and probably also to the episodes of anemia. What about other channels, in this case pumps more than channels? Well, ATP1A2 and 3, as you know, have been associated mainly with hemiplegic migraine for the A2, with alternating hemiplegia for A3, plus some additional phenotypes, especially rapid onset Parkinson's and dystonia. Now, recently, in a collaborative study, we associated the mutations in both of these genes with polymicrogyria, which means that the consequences of the alteration are already present before birth. But what is more important for discussion today is that there were also in this cohort patients with migrating focal seizures without an apparent brain malformation at the beginning, but in two subsequent scans showed progressive atrophy. This is two examples, and there are two patients scanned at, I think, 1 month and 13 months here, and 7 months and 3 years here. And the progression of atrophy, which involves both the brain and the brainstem is obvious. So this is epileptic encephalopathy with a clear atrophy related to migrating focal seizures. Now, migrating focal seizures are actually a very heterogeneous condition with multiple etiologies. So in spite of a similar electroclinical presentation, these patients may have very different etiologies. And this is the nice paper by Burgess and others. And you see here that in a very large international cohort, there were about 31% unsolved cases, but for the others, there was an overwhelming number having KCNT1, and then the other was scattered amongst many different genes, including SCN2A, 1A, and many others, including some genes which may cause obviously progressive atrophy, like the glycosylation disorders, as you can see here. So you cannot understand from the very beginning whether this is a condition that will entangle progressive atrophy, but etiology is very important. Multiple function protein, CDKL5, you have seen some studies about EEG, but there is only one interesting study together with Nicola we conducted. This is a relatively small but interesting series where we performed 35 scans in 22 patients. And you see here that there was statistical evidence of progressive atrophy in a quantitative morphometric study. Of these patients, you see, for example, 12 had a normal neonatal MRI scan, a first MRI scan. Out of whom were scanned again between age 2 and 23 years and had brain and cerebellar atrophy, which were not apparent in the first scanning. There was a volumetric brain reduction, and which included both the gray and the cortical gray and the white matter, with an important reduction of the surface area, which was about 18%. And that correlated with the head size. As you know, CDKL5, they do not have severe microcephaly. They usually have a borderline head circumference, but then tends to decrease over time. Now, of course, the population here where the contribution of the genetic mutation and the very severe seizures remains to be determined. Cytoskeletal and extracellular matrix proteins. Just to provide you with one example of what I mentioned in the beginning. This is a nice paper in 2010 when the team of Naomichi Matsumoto described dominant negative mutations of the spectrin alpha-2 causing West syndrome and brain hypomyelination with consequent spastic quadriplegia, developmental delay. So this is a typical syndrome. And what they describe is here. You see a very thin corpus callosum and atrophic brain changes, small cerebellum. And then they could demonstrate that the basis for this was an aggregation of alpha and beta spectrin heterodimers, both in lymphoblastoid cells and in mouse cortical neurons. But that was a description. They didn't know whether these malformation, these brain atrophic changes were stable or progressive. In a subsequent study, we gathered a large collection, mainly Europe, but also from Japan, and could demonstrate that the atrophy is severe and progressive in most of the patients. It is so when the mutation falls in the heterodimerization domain with the precipitation of heterodimers. And you see here how severe may be the atrophy in some patients like this. It is already obvious early in life, but becomes much more severe. And sometimes it predominates in the cerebral cortex and white matter, sometimes predominates in the brainstem and cerebellum, but it's really severe. While other patients with mutations falling in the first 1 to 20 repeats, the MRI was normal, the cognitive impairment was mild, and epilepsy was focal and variable. So two entirely different phenotypes, no evidence of progression in these patients, and severe progression in these other patients. Oh my goodness. Okay. Now, vesicle acidification and autophagy. This is a condition which we associated with Lennox-Gastaut syndrome. These patients have mutations in the ATP6V1A gene, which is a multimeric vocolar ATPase dependent proton pump. It regulates pH homeostasis in cellular organelles, mainly in lysosomes, but also in other organelles. This is an initial description. There were 4 patients. Their brain MRI scans showed very mild atrophy changes. They only had 1 MRI scan. And we could also demonstrate that some structural abnormalities were likely present, even if not demonstrable here, because when transfecting hippocampal neuron of the rat, there was a very poor arborization, as you can see in these examples. Then, together with an association that was created by a family in the United States, within the next 2 years, we could gather 26 patients, something like that. And many of these patients were scanned twice. And it became evident that this epileptic encephalopathy had brain atrophy in some patients. It didn't have it in some others, but all patients who were scanned twice had a progression of atrophic changes. And the basis for this was related to, we could demonstrate in the IPS-generated neurons, where there was inclusion of redundant abnormal lysosome scattered in the cells. And this was also demonstrated with electron microscopy, both in those neurons and in the fibroblasts, and also confirmed the arborization compromise. And this is another story. I want to make it short, not to go beyond time. This is another DMX-L2. Is expressed, highly expressed in synapses, but also for intracellular signaling, and again, like the previous disease, regulates VTPase assembly. And here again, even if these patients are very severe from the beginning with Otahara syndrome, and tend to be progressive very quickly, and this is also shown by the MRI scan. I will not spend more time here and conclude. So there are no generalized conclusions possible, because these are many rare conditions. Many studies have oversimplified the contribution of imaging to the understanding of progression, and do not report follow-up scans. Neuroimaging follow-up may be, as we have seen, as variable as is the clinical outcome, even within the same entity, but may change in relation to different mutations of the same gene in the same condition. The cumulative role of the underlying neurobiology, the seizure burden, and drug load may be difficult to disentangle. In that area, we still really don't know. Quantitative studies capable of detecting even subtle imaging changes are only possible in relatively frequent conditions, and it's not by chance that we only have done this kind of studies in Dravet syndrome, SC1A, CDKL5, because they are relatively frequent among the various severe disorders. Repeat neuroimaging is, in my opinion, always indicated, because can disclose surprises that clinically we might not suspect. And in order to do so, multi-center studies would be needed with specific imaging protocols for specific syndromes. Thank you for your attention.
Thank you very much. Great talk. So, we're running a little bit late, but if there are questions, please approach our people with the mic. There.
Hello. Thanks very much, Robert Robinson from London. So if I understand correctly, in many of the DEEs, there isn't a close relationship between the severity of the ongoing seizures and the poor developmental outcome. So if I'm correct in that, does that make you quite pessimistic that the improved seizure control that we're seeing with some of the newer anti-seizure medicines is actually not going to improve long-term developmental outcome?
Great. Go.
Okay, thanks for the easy question. I think it's both ways, Robert. I think it is some genes and some severity relates directly to biology. Sometimes it does relate to seizures, but again, going back to Dravet, because we have such a big experience of it, you have patients who are cognitively better with very frequent seizures and patients who are cognitively severe intellectual disability with relatively infrequent seizures. I think you do see a correlation, but I don't think it always holds forth, and that's where these polygenic risk scores, etc., are interesting, because they might start to give us a handle on other contributing factors. But then I think Renzo's cases also highlight when you've got really severe disease, a really severe gene or protein malfunction, you're sort of in big trouble no matter what. So I'm having it both ways.
No, I agree. There's nothing to add. Exactly what I think.
Lieven?
Well, I'm really convinced already right now that because we are reducing status epilepticus much better than 10, 20 years ago, that the outcome of our Dravet children is already now much better. The figures that you saw, all these cross-sectional study, that after the age of 10, that the developmental quotient is less than 50 or 40. I think if you would do a study right now, that's what is being done, we will see better figures. So there is a role, of course, for reducing the seizures as much as possible, especially the status epilepticus. But I don't have any hard data on that.
And just a brief comment, I was wondering whether, also we will restrict the story to the seizure per se, because it's not the case, of course, it is multifactorial, but restricting to the seizure, perhaps it would be worth to consider at which age was the maximal activation, which seizure type, making a little bit more articulated than just considering the latest follow-up or the onset. Isn't it the case? Or?
Yeah, I think you're right.
Yeah, and just, I didn't answer one thing about the medication. I think if you have anti-seizure medicines that influence seizure frequency and control seizures, you see the children make developmental progress. They don't normalise, but that's the hope of the gene therapy, isn't it? That we will get in at a much more fundamental level and improve outcome. I have a question for you, Renzo, which is those studies you've shown are dramatic. And are there particular protein mechanisms that you think cause this very severe atrophy? Can you put them into groups? And is there a group that you think is much more likely to give this severe atrophy versus mild atrophy that we see in many patients?
You are referring to specific conditions or some in general?
Yeah, I'm referring to all those different brain papers. You showed us many brain papers, and can you start to conceptualize there are particular proteins that cause this much more severe atrophy, or groups of proteins?
Well, I think that scaffold proteins are really a good target for atrophy, and I think that there are many genes which are expressed in the organelles whose pathophysiology is not known, that cause epileptic encephalopathies, perhaps not in all patients, but in many patients that are suitable for causing these atrophic changes, which may not be obvious early, but become obvious over time. Yes.
Can I add something? I was thinking about you saying that severe atrophy, there are some group of genes. That's nice. But to answer the question, is that relevant if the atrophy is mild or severe? To answer the original question, so if neuroimaging shows a progression of the disease, I mean, if it's a mild, even if it's mild, still we do have a progression of something.
I mean, one thing is the neurobiology of the disease, and other thing is the expectations you have for that patient to be rehabilitated or provide some benefit when you make him seizure-free or perhaps improve his seizures. If the atrophy is very severe, you should not overemphasize, as Leven said, the role of treatment and so on. Because
I agree, definitely. I was referring to the neurobiological process. So if we say those are progressive disorders, yes or no, even if the atrophy is mild, still we do have some kind of certain degree of progression.
Yeah, the point is that in some of these disorders, as you have seen, there is a big variability. Sometimes it is mild and remains mild. Sometimes it becomes very severe.
Yes. And maybe since the trajectory inside the same spectrum of phenotypes may be different for the same gene, sometimes, for example, the epilepsy outcome doesn't correspond to arrest of the progression of the disease. Sometimes just the seizure stops and perhaps subcortical neurological symptoms comes up in a severe way, as we've seen for some gene, for example. So maybe perhaps a more global consideration of outcome on different planes, not just epilepsy, maybe better reflect the progression of the disease.
Absolutely. Yes.
Questions from the audience?
I think I've had it.
Sure. Okay, so thank you very much for being till the end. And now I think there is the coffee break, so have a relaxing half an hour. Thank you.